Dear colleagues, this lecture will deal with ultrasound surveillance and diagnosis of hepatocellular carcinoma. These are my disclosures. Screening is the application of a test to detect a disease in a population which has no signs or symptoms of that disease, while surveillance is the periodic repetition of the screening test in the same population. Both aim to detect a disease before it becomes symptomatic, at an early time point of its natural history, when treatment is more effective, with the ultimate goal of reducing disease-specific mortality. When screening or surveillance are cost-effective, when they fulfill the seven PROC postulates. The first of which is that the disease must be common with substantial morbidity and mortality. In the case of liver cancer, this is the fifth most common cancer and the second most frequent cause of cancer-related death globally. Therefore, it is obviously a very common and very dangerous disease. This is not only in Europe, represented in this picture, it is also in Asia, and it also in the United States, where the liver and bile duct cancer, and mainly the liver cancer, are the ones showing the highest rate of increase in the recent years. Then, having a disease which is common with substantial morbidity and mortality, we must have a target population. And this will be illustrated later, is present for the patients for the case of hepatocellular carcinoma. Surveillance tests must have low morbidity, high sensitivity, and high specificity, and imaging techniques do fulfill these conditions, particularly ultrasonography, as it will be illustrated later. The surveillance test must be acceptable for the target population, and if we think at ultrasonography, obviously this is very well accepted by patients. And there must be standardized recall procedures which will make the second part of this talk in the diagnosis of hepatocellular carcinoma. But most importantly, when we have proceeded to the surveillance and we have identified the patients who have been submitted to recall procedures, we must have acceptable and effective therapies. And this is fortunately the case, most of all for the possibility to transplant patients with early stage liver cancer, but also because in recent years there have been a really very important improvement in the effectiveness and the capacities of systemic pharmacological therapies for hepatocellular carcinoma. And therefore the ultimate goal is to reduce disease-specific mortality and prolonged survival, which is what the current treatment of hepatocellular carcinoma is becoming more and more importantly able to provide. How can we show that surveillance provides longer survival? This can be demonstrated comparing patients who have been detected under surveillance to patients whose hepatocellular carcinoma was detected out of surveillance programs. And you can see that the 3-year survival rate is longer in patients detected during surveillance in different case series. Unfortunately, however, before we can draw the conclusion that surveillance is effective, we must get rid of the lead time bias, which is the risk that we state that the life of the patient is longer simply because we detect the tumor at an early time, even though we are not able to prolong the survival. But this on its own make a longer time interval between the diagnosis and the death, regardless of the capability of prolonging survival. To get rid of this is possible by statistical method and considering the doubling time and the size of the tumor at detection. And actually, when looking over different terms perspective, in the first 3 years, actually the longer survival is indeed in surveilled patients mainly attributable to the lead time bias. However, when we look at the longer perspective, in a 10-year perspective, then, as these curves very well show in this simulation, patients who had received a semi-annual surveillance every 6 months live longer, have a higher um, probability of being alive than patients under annual surveillance and the patient not receiving surveillance. Therefore, looking at the long-term perspective, there is a benefit of surveillance. Obviously, the strongest evidence would be provided by randomized controlled trials, but unfortunately, in this setting, we do only have one randomized controlled trial, which is also not the perfect one because the compliance was relatively low, only 58%. Patients could be not offered liver transplantation, which is the most effective therapy, but nonetheless, the patients who had been submitted to surveillance at a lower probability of death, and the hazard ratio was 0.63, indicating benefit of surveillance. Unfortunately or fortunately for our patients, there will be no more any randomized controlled trial because patients at present, as has been demonstrated by various studies, are no longer available to be randomized to the control arm not receiving surveillance. Therefore, there is no room anymore for randomized controlled trials in the setting of ultrasound surveillance or surveillance at all for patients at risk of hepatocellular carcinoma, and we must rely only on the data that are available so far, mainly based on the case series. So overall, we have to look at these studies with long-term follow-up. Another potential risk of bias in assessing the benefits of surveillance is the length time bias, which means that tumors which are emerging with a very rapid growth, they will become symptomatic before the patients are submitted to any additional diagnostic test, and they are detected as symptomatic compared to tumors which have a slow growing pattern, which will be detected at the next imaging appointment. Therefore, patients with a more indolent course will be detected and will be subgrouped in the surveillance group compared with patients with very aggressive tumors. However, in general experience, this is not a very common case in liver cancer, and the real-life data showed that in a randomized controlled trial comparing 3 months interval of surveillance with 6 month interval, there were no improvement in life expectancy in patients who were submitted to a shorter time interval. And most of the patients on short time interval were detected with tiny lesions which ultimately did not achieve any diagnosis of cancer. Therefore, the shorter interval was not cost effective, and this denies the risk of a length time bias occurring in the surveillance of hepatocellular carcinoma. With this in mind, we go to real-life data. What do we miss when we propose surveillance? In real-life data from the Idalica database, the patients diagnosed under surveillance had a smaller median size that corresponded to 2.6 centimeters and a longer doubling time, 100 days, which means that indeed there could be a potential risk of length time bias, but these do not apply to the majority of patients. But what is important is that the median size is 2.6 centimeters, which means that patients are indeed detected still within the early stage, which is less than 3 centimeters, but not with the best opportunities, because meta-analysis showed, and this is a meta-analysis that we performed some years ago, that if you are able to detect tumors less than 2 centimeters, you can provide survival at 3 years in the range of almost 90%, compared to slightly larger tumors up to 3 centimeters instead of 2, whose survival when submitted to radiofrequency ablation decreases by about 12%. This is not a big step, but shows that even slightly bigger tumors have a bit worse prognosis. Therefore, the aim of surveillance should be to detect tumors smaller than 2 centimeters. Moreover, there is a number of tumors which are detected because they become symptomatic despite surveillance. This is about slightly less than 1/5 of the cases, which means that probably the previous imaging at the previous interval missed the lesion. Why does this happen? Because ultrasonography, unfortunately, is not the most sensitive technique. Its sensitivity was demonstrated to be in the range of 60 to 70% of a hepatocellular carcinoma. However, this is very well applicable technique, very well received by the patients, a cheap technique. Therefore, despite suboptimal in terms of sensitivity, ultrasonography still remains the best compromise. Having all this in mind, the conclusions are, and these are those provided by the European Association for the Study of the Liver, that patients at high risk of developing hepatocellular carcinoma should be entered into surveillance programs, and that surveillance should be performed by experienced personnel in all high-risk population using abdominal ultrasound every 6 months. Obviously, we cannot utilize CT for surveillance because we would require a repeated injection of iodinated contrast agent, which accumulation of iodine, and also exposure to radiation hazards, which is not acceptable in patients who have no cancer. MRI could be an alternative possibility, but also in this case, we should not utilize contrast agents because gadolinium tend to accumulate in the brain. And therefore, the only alternative to ultrasonography could be non-contrast enhanced MRI, which is a possibility, but at present in most countries it is far too expensive to be applied to all patients at risk of hepatocellular carcinoma. Therefore, considering ultrasonography as the surveillance tools, what are the limitations of this technique? Some are related to not modifiable factors. For instance, lesions which are isoechoic will remain invisible, especially when small. Some are partially modifiable, and these are related to on one side, on the suboptimal explorability that may be improved partially by using better equipments and by resorting to more experienced operators, and this is also what the guidelines recommend to deliver surveillance by examinations performed by skilled personnel, but even simply reporting cases where the explorability is suboptimal so that the physician in charge can require MRI or alternative techniques in case of suboptimal explorabilities. This is an example. We don't see any lesion in this cirrhotic liver. When we use contrast enhanced ultrasound, there is obviously a lesion which has washout, but this is not visible on conventional ultrasonography simply because it is isoechoic. This also is a tiny lesion, but contrast enhanced ultrasound in the arterial phase shows that there is an additional second lesion, very tiny lesion, that, knowing its presence, is probably detectable, but this might for sure go overlooked under conventional standard care with most equipments and with most operators because it's hardly visible despite an improvement in the quality of ultrasound scanners and in the capacity of the operators might increase the number of cases in which even these tiny lesions could be detected in the future. Moreover, livers might be inhomogeneous, so they might present pseudo lesions, and this might cause problems in indicating whether these regions deserve further investigation with contrast or not. And these are limitations which also require or could benefit from improved equipments improved quality of equipments, and improved skills of the operator and experience in differentiating true lesions from pseudo lesions. One of the most important limitations at present is the increasing number of cases of non-alcoholic fatty liver disease in overweight patients. These often suffer suboptimal explorability, and we have to decide whether they are nonetheless acceptable, whether this patient might be referred to expert centers, or whether they should receive MRI instead of ultrasonography. And this is still a problem which has no solution. Obviously, experienced operators might adapt the setting of the equipment to improve, for instance, in this case, decreasing the frequency. These are all tiny tricks which not all operators are able to utilize. Therefore, it is strongly recommended that these patients are visited by skilled operators. So, to summarize, in my view, the degree of explorability of the liver has to be included in the report, whether the explorability is complete, whether it's good but suboptimal, or whether it's poor, so that decisions can be taken from this indication. It also must be specified which specific equipment had been utilized, because this is often not the case. Could be recognizable from the images, but often this is not the case. So the referring clinician does not know whether his patient has been investigated with the highly performant ultrasound scanner or not. And also images are not often or not always attached to the report, and therefore it would be important to select key images to be delivered together with the report. And also, potentially in the future, a certification of the expertise of the institutions performing this examination should be provided. Which are the patients to be surveilled? Which are the patients at risk? The patients who have a risk of at least 0.2% yearly of hepatocellular carcinoma if non-cirrhotic, because they more easily can receive surgical resection, which is a curative technique, or in case of liver cirrhosis, which most hardly can receive most of the most curative techniques, the early incidence should be at least 1.5%. In case of patient with hepatitis C, this incidence is obviously occurring when there is over-cirrhosis, liver stiffness above 15 kilopascal. But even patients of pre-cirrhotic condition with a stiffness between 10 and 15 are probably in need of surveillance. The rates are higher in Japan, which is the case in this image, but even in European and Western countries, these pre-cirrhotic conditions have to be analyzed on an individual basis, because most of them would be in need of surveillance. If patients are treated for the hepatitis C, do they still require to undergo surveillance? The answer is yes, because the achievement of sustained virological response actually do almost completely abolish the risk of developing cirrhotic-related complications like liver failure, ascites, but it only slightly decreases and does not abolish at all the risk of developing liver cancer, as can be seen from the lower image. And for hepatitis B patients, in the past there was a recommendation not only to submit all cirrhotic patients to surveillance, because this is the case, all cirrhotic patients in child pug liver function stage A or B should receive surveillance regardless of the etiology. In case of hepatitis of child pug stage C, which are decompensated cirrhosis, only those awaiting transplantation, because this modifies their priority. But in case of hepatitis B, also non-cirrhotic patients should require surveillance. In the past, it was reserved to all active hepatitis, but the European guidelines updated this recommendation and nowadays does not require surveillance for all active hepatitis B but only for those at intermediate to high risk according to this score named page B. Page B is based on gender, age, and platelet count, and it provides three classes: a score up to 9, 10 to 17, and more than 18 or more. And as you can see, the higher score have a higher risk of hepatocellular carcinoma. The intermediate score has still a substantial risk, while the patient with the lowest score have a negligible risk of hepatocellular carcinoma. Therefore, despite suffering from active hepatitis, it is not cost effective to submit this patient to surveillance. And if patients are receiving antivirals, do they still require surveillance over the long term? The answer is yes, for which we know so far, but probably in the future, if this data will be validated, the patients in the page B score with the low grade at baseline would not require surveillance because the risk would become so low that surveillance would be no more cost effective. In the case of non-alcoholic fatty liver disease, the situation is instead less clear. We know that all those with cirrhosis deserve surveillance, but we know that 50% of HCC develop in non-cirrhotic livers in case of non-alcoholic fatty liver disease. But for these patients, we have no clear risk factor for which we select patients with a risk of HCC high enough to mandate surveillance. So an individual choice should be taken, and the factors are still not well known. Probably diabetes is a very strong risk factor, male gender as well, and age, and probably in the future also some biomolecular markers. These unfortunately are at present not strong enough to make a general recommendation for recommending surveillance in non-cirrhotic, non-alcoholic fatty liver disease. Now we have come to the situation where our surveillance has detected a lesion. When we see a lesion, what is it in patients at high risk of hepatocellular carcinoma? These are several studies, but to summarize, obviously, the most likely diagnosis is hepatocellular carcinoma, which represents 65 to 80% of newly detected lesions. But if not an hepatocellular carcinoma, about 50% are still hepatocellular lesions, regenerative nodule with or without dysplasia, whereas the remaining 4 to 5% are represented by hemangiomas, cholangiocellular carcinoma, which is about 2% of all new lesions, and more rarely lymphoma or metastasis or other extremely rare entities. Therefore, when we see a lesion, we need recall strategies to distinguish these different lesions and possibly to achieve a diagnosis of hepatocellular carcinoma. The recall procedures are different according to different international societies. The American Society for the Study of the Liver updated their guidelines but did not modify their pattern. Therefore, they still endorse only CT and MRI, and they have only one single definition of the typical pattern, which is arterial phase hyperenhancement followed by washout. And according to this definition, the use of contrast-enhanced ultrasound was prohibited because when we adopt simply this pattern, approximately half of the intrahepatic cholangiocellular carcinoma developing in patients at risk of hepatocellular carcinoma do have the same pattern of hepatocellular carcinoma, and therefore they suffer a risk of misdiagnosis. Altogether, these are very few patients, but actually adopting simpling hyperenhancement plus washout is not sufficiently specific. However, the European guidelines in 2018, and I was happy to contribute to these guidelines as a co-author, refined the use of imaging techniques, not adopting the same definition for all imaging techniques, but modulating, fine-tuning the definition of the typical pattern according to the imaging modality, whether CUS or CT or MRI, and in case of MRI, with different definitions for different contrast agents. Therefore, if we think in contrast enhanced ultrasound, it is no more enough to have arterial phase hyperenhancement followed by washout, but the washout should have a late onset starting after 60 seconds and be of mild intensity. This is the only pattern which is acceptable to achieve a diagnosis of hepatocellular carcinoma and correspond to the CUS LR5 pattern. Therefore, the guidelines now recommend to start with CT or MRI, which is here, simply because they are very good at staging the disease, so at screening for the presence of other lesions beyond the one that is the target of our investigation. But if this is inconclusive, they accept either resorting directly to biopsy or to go to an alternative technique, which includes also contrast enhanced ultrasonography, which is therefore endorsed as a technique able to definitively achieve a diagnosis of hepatocellular carcinoma. So the different definitions for the typical hepatocellular carcinoma are for CT the presence of hyperenhancement followed by washout, either in the portal or in the delayed phase. This is a typical image, arterial phase, early arterial phase, late arterial phase, which shows hyperenhancement, and start of washout in the portal venous phase, which becomes more evident in the late phase. Typical pattern at CT. With MRI, with the conventional contrast agents without a hepatospecific phase, the hyperenhancement in the arterial phase is typical when followed by a washout, regardless of whether it occurs in the portal phase or in the delayed phase. This is an example, arterial phase hyperenhancement followed by washout in the portal phase and in the delayed phase. In case instead of use of hepatobiliary contrast agent, there is also a late phase or post-vascular phase of hepatobiliary phase, in which tumors show an enhancement defect. However, with gadolinium AOB, acetic acid gadolinium, the uptake is relatively rapid. Therefore, it might influence already the delayed phase. Therefore, to have a diagnosis of HCC, the washout must occur as early of the portal venous phase. Therefore, in this example, this pattern cannot be held a definitive diagnosis of hepatocellular carcinoma and might, for instance, be also a cholangiocellular carcinoma, despite very rarely. Whereas, if the portal venous phase already shows a washout, this pattern is typical regardless of the type of gadolinium-based contrast agent, and this is the image. Therefore, to sum up, at present, a diagnosis of hepatocellular carcinoma can be achieved in lesions which have been found in cirrhosis, in patients with cirrhosis, and I would like to remark that the recall strategy only applies to patients with cirrhosis because of the high probability, a priori probability of hepatocellular carcinoma, and this diagnosis can be achieved by CT or MRI with specific contrast pattern, or with contrast enhanced ultrasound with specific pattern, and contrast enhanced ultrasound is able also provide additional information which have, however, to be presented separately. I would like to thank all of you for your attention and to thank all my co-workers at the medical staff at the Division of Internal Medicine for supporting all our activities.